Namaste, greetings. My name is Dr. Deepthi Adappa, Assistant Professor from the Department of Oral Medicine and Radiology, Yenepoya Dental College. My topic for today will be Bitewing Radiography. Moving on to the specific learning objective, I hope by the end of this you all have an idea about Bitewing radiographs, its uses, indications and its techniques and certain errors that may occur if not used properly. These are my contents. So, if you can see broadly on a larger scale, there's three radiographs that come under intraoral radiography. Intraorally means the radiograph film that you place inside the oral cavity. So, under that we actually have the periapical, bitewing and occlusal. So, the main difference between periapical and bitewing, you can see it in the word itself, periapical. So, you can be able to appreciate the apex in the IOPA film, that is the periapical film. Whereas in the bitewing, let's show you this image, you can clearly see both the arches, the mandibular and the maxillary arch, along with that the supporting bone structure, the alveolar crestal third, both in the upper and lower, and also the cervical third of roots of both the upper and the lower areas. Whereas in the periapical radiograph, you can appreciate only one arch firstly, and it's more for the assess the periapical areas. And you can clearly see the bones are also more easily visible. You can detect the level more easier in the bitewing as compared to the IOPA, and even horizontal overlap is more common in the IOPA as compared to the bitewing, which is why in bitewing one of the main uses is we are assessing the interproximal areas, basically the areas between each teeth. As you can see, because there won't be overlap, you'll be able to assess the alveolar bone also in the bitewing. Hence, the other name also for bitewing is interproximal technique. So, let's read up. The bitewing technique or the interproximal technique is a method used to examine the interproximal surfaces of teeth. This includes the crown of the maxillary and mandible teeth and the alveolar crest on the same radiograph film or receptor. So, as you can guess what the indications are, right? So, whatever is what we need to assess between each teeth, what are the most common things we need to assess between teeth? The bone, and if at all, why do we need to assess between two crowns? Mainly you can talk about the proximal caries. So, let's move on to indications. You can detect the early interproximal caries before it becomes clinically apparent. You can assess the loss of interdental bone and furcation bone. So, you can clearly see it is useful in assessing periodontal conditions, and also along with that you can also detect the calculus deposited in the interproximal area. Since the calculus is of lesser density, for better visualization it would be advised to we'll have to reduce the kVp and MA, the radiation, to better assess the calculus. I'll show you the sample images after this. To detect secondary caries below restorations, that's the next indication. Then in monitoring the progression of dental caries and in assessing overhanging restorations. So, we'll show you a few examples of these indications. Here you can clearly see it's a very small proximal caries which wouldn't have been visible otherwise in the IOPA, but here you can clearly see it in the bitewing, interproximal caries. In the next example, you can clearly see the bone level. Bone level is much lower, it's almost at the cervical third bone loss or reaching up to the mid third level. There is a clear horizontal bone loss present both in the upper and lower arches. So, the normal distance usually in the radiograph is between the alveolar crest to the CEJ is about 1.5 to 2 mm. You can clearly see it over here, whereas here also. But here in the bone loss you can clearly see the CEJ ends here and the crest is way beyond 2 mm in all the premolar and molar region. So, hence it is useful in assessing for periodontal conditions also. Here you can assess the calculus. It's of less density, but it's clearly visible over here in all the teeth. Next, you can, if you see closely, you can see there's a radio opacity here which is suggestive of restoration, below which you can see a radiolucency suggestive of secondary caries. In this example, you can see the overhanging restoration, as again this is for studying the interproximal region, right. So, it is also useful in overhanging restoration. Then another thing main point I would also like to add is certain studies have shown that there is this thing called cervical burnout, which is usually seen between the CEJ and the alveolar crest. A radiolucency occurs. It is actually not caries, it gives the illusion of caries, and this is known as cervical burnout. In the IOPA films it is more common. Certain studies have shown this cervical burnout is lesser in bitewing radiographs. As you can see over here, cervical burnout tends to occur between the CEJ and the alveolar crest, and here the cervical burnout is very less and the radiolucency is barely present as compared to the IOPA. And just another example, we have the proximal caries just for additional information. Moving on to film holders. How is the film held in place in the oral cavity? What is a film holder? A film holder is used for stabilizing the film. Those used for bitewing radiography are, there is two main film holders for bitewing, that is the RIN XCP bitewing instrument. At the end of this PPT, I will also be giving a live demonstration of these two film holders. We have the RIN XCP like I said, and then there is the bitewing tab. First we will move on to the RIN XCP bitewing instrument. It mainly consists of three things, that is the plastic bite block, the plastic aiming ring, and the metal indicator arm. So, you can see over here this is the whole structure, and over here you can see the plastic bite block is this piece over here, and you can see it individually, you can appreciate it over here, and in the bite block the film is held in place, you can see over here, and the patient bites on this area. As you can see, this is intraorally, you won't be able to appreciate it here, but this is where the patient bites in this area. Okay. So, then we have the plastic aiming ring that is visible over here, and on instilling it in the patient, it is present extraorally. It is the aiming ring, and attaching the bite block and the aiming ring, you have the metal indicator arm. As you can see clearly over here, this is the metal indicator arm. So, on the whole, you can see the aiming ring helps in positioning for the PID, the position indicating device, or the X-ray tube. It helps it in the proper angulation is not required here, as the aiming ring is already there. So, it is very user friendly and it is not technique sensitive. The one more advantage of the RIN XCP is these RIN XCP are reusable. So, what we do is the bite block that is here, we use a sterilized cover over the whole area after applying the film, and it is applied into the patient's mouth. So, this makes it more useful in terms of we can reuse the RIN XCP as compared to the next thing that I will talk about, that is the bitewing film. The bitewing tab loop. So, here this is disposable and it is made of stiff cardboard or plastic, as you can see over here. Here this is the loop area and this is the tab. So, this loop is where the film is installed. Okay. So, and how the film is installed is the white part of the film will be facing the tab. So, this tab area is where the patient will bite. As you can see in this image, the film is placed intraorally. This is the tab where the patient will bite, and extraorally is where the central X-ray will be coming from. Then we also have the ready-made bitewing film, such as this film over here. You can see the tab is already attached, glued to the film. So, these are the various types of bitewing tab loop, and you can clearly see where the name bitewing came from. The only disadvantage of the bitewing is that it is again technique sensitive as compared to the RIN XCP. In XCP you have the aiming area, so the angulation is not taken into consideration, whereas over here you just place the film and the angle is very much important, which I will talk about shortly. So this is what is the angulation and PID? Like I said, if the RIN XCP is used, the aiming RIN dictates the proper PID angulation, as you can see over here. Few more examples where very easily the PID is just made into same alignment with the ring, aiming ring. So in the Bitewing, the angulation is important. So what are the two angulations we take into consideration? The horizontal angulation and the vertical angulation. In horizontal angulation, the central X-ray is directly perpendicular to the curvature of the arch and through the contact areas of the teeth. Now what do we mean by that? Here you can clearly see the central X-ray, and it is, what are they saying? They are saying it's directly perpendicular to the curvature of the arch. As you can see, the arch can curve over here, especially in cases whether you are taking a premolar, and you can see the central X-ray is perpendicular to the curvature of this area. The premolar clearly curves in this area, so the PID should be positioned in such a way that the central X-ray is perpendicular to this arch near the premolar. Whereas if it is the molar, you can clearly see the horizontal angulation changes, and it should run through these contact areas. And if in case if it is not done properly and the horizontal angulation is not perpendicular to the contact area, in this case you can see it is slightly moved, horizontal angulation is not proper, and the central X-ray goes through each contact area. What does it result in? It results in horizontal overlap. You can clearly see between each tooth there is a overlapping, thereby the whole concept of the use of Bitewing is gone, where you are not able to appreciate anything in the interproximal teeth surface areas. Now vertical angulation, how much? It is plus 10 degrees. There is a reason to it. Why is that? As you can see here, the intraoral film, right? This is on the lingual aspect, and you can clearly see the palatal, due to the palatal bone over here, the film tends to bend mildly to plus 20 degrees. Around plus 20 degrees it tends to angle, whereas as the film comes down here, it is 0 degrees due to the alveolar bone on the mandible is straight, so it's giving us 0 degree angle. So to average this whole thing, we are giving an angulation of plus 10 degrees. Moving on to the positioning of the patient, first and foremost, briefly explain the procedure. Let the patient warm up to the whole concept of it, as you are going to be slightly invasive for him, right? In terms of you are going to put a whole device into his mouth. The RIN XCP is quite a large, could be intimidating for the patient. Make the patient sit upright, and next the chair is adjusted to a comfortable working position. Adjust the headrest to support and position the patient's head, as you can see in this image, so that the upper arch, you can see the dotted line here, is the upper arch is parallel to the floor. So clearly his nose shouldn't tip down, which is almost straight. Basically the maxillary arch is perpendicular to the floor, and the mid-sagittal plane, you can see the imaginary line here through the center, should be perpendicular to the floor. So parallel and perpendicular. Okay, so this is the main position of the head. Then secure in terms of radiation protection, secure the lead apron and the thyroid coil on the patient, and of course remove all foreign objects from the face and the mouth. So moving on to the Bitewing projection, there are mainly two types, that is premolar and the molar. In the premolar, how should an ideal image appear in the premolar Bitewing projection? The image field should basically show the distal portion of the mandibular canine, and it should equally show the crowns of maxillary and mandible premolar. What do they mean by that? In an ideal image of a premolar Bitewing projection, you should be able to appreciate, you can mildly see the distal aspect of the mandibular canine. So that's where the image should start in the anterior aspect of this whole image. And of course, we should be equally able to visualize the mandible and the maxillary teeth. And you can clearly see here the whole oral cavity. The image should be placed in such a way. So, even the film also obviously should be placed in the same way, such that the anterior border of the film should be in the distal aspect of the mandible or canine. Why is this done? So, we are clearly able to appreciate all the 4 premolars of the maxilla and the mandible area. Okay. And one more thing about film placement in the premolar bitewing projection is, place the film mainly between the, if the tongue is over here, between the tongue and the teeth, and as far from the lingual surface of the teeth. Why is this done? To prevent any interference of the palate. As you can see over here, what they have advised is the film should be slightly away from the lingual surface, but over here you can clearly, if this is the lingual side, the film should have been placed little more away. Why is that? Because the palatal bone over here can, if the film is too close to teeth, it can tend to push it down. As you can see on closing clearly how the film has been fully pushed down. Moving on to the molar bitewing projection, same thing. How should an ideal molar image appear? It should be such that at the end of the day, all the molars should be clearly visible. So, first and foremost, assess how many molars are there. That is, I am counting the erupted third molars also. If there is an erupting third molar, that also should be considered in the ideal molar bitewing image. Okay. So, in the image field, this projection should show the distal surface of the most posterior erupted molar. What do they mean by that? The distal most aspect of the, in this case you can clearly see the third molar. So, up till the distal aspect it should be clearly visible. And of course, same concept, the next part is that all the crowns of upper and lower should be visible. Now, in terms of placing the film, so like I said earlier, it should be placed in such a way that all the molars are visible. One way you can do is, the distal aspect of the film should extend 1 to 2 mm beyond the erupted posterior molar. So, you can see over here the film there is a clear distance from the posterior aspect of the film and the posterior aspect of the tooth. There is a distance between 1 to 2 mm. When we do this, automatically all the molars will appear on the image. And again, slight distance should be maintained, same concept, lingually, so that the palatal bone does not push the film down. And also this area tends to be a little sensitive for the patient, so that also it prevents any pain on the patient as well. Now, how should the central ray be? The projection of the central ray to the center of the receptor and through the contacts of the first and second maxillary molar. So, the central X-ray, the imaginary central X-ray should basically go between the first and the second molar. Where is the point of entry? Where should this PID be? It should enter the cheek area near the outer canthus of the eye this is the outer canthus over here. At what level? At the occlusal plane level. So, in this way you can clearly place the PID in alignment with the film. So, thereby preventing any cone cuts also. Whereas in the premolar, you will be able to retract the cheek and also be able to make sure the PID is in alignment with the film. But in the molar, you are not able to do that. So, this will be the point of entry. So, when you do this, it should be in such a way that the central X-ray will go between the first and the second molar. Okay. Now, there is certain modification in this technique, such as what do we do when the teeth is missing? They clearly, we mentioned 100 times, there is a bite block in the RIN XCP. In the bitewing, there is a tab that they need to bite on and there is no teeth. What do we do? It's simple. We just place a cotton roll in, you can see there is missing teeth here. Just place a cotton roll there so that the tab will have support. If the tab does not have support, this whole tab will go down and in the process, the whole film will get angled and you will not get the ideal image. Now, the another modification is known as vertical bitewing. In the regular Bitewing, you clearly saw the film is horizontally placed. But in this case, what we do is we place the long axis of the film is vertically placed. Why do we do this? One of the main reasons is when you saw the ideal image in the Bitewing, you could only appreciate the alveolar bone in the crestal third, right, up to the cervical third level of root. But in this case, in case there is severe bone loss, where there is bone loss up till below the mid and apical third, you won't be able to appreciate it. Let me show you some examples here. So you can clearly see the film is vertically placed. Thereby, you will be able to appreciate severe bone loss. Here you can see, let's find, yeah. Here you can see it has gone up to the mid third, so at least till there you can appreciate in this case. Here the severe bone loss here, you can clearly see the CJ is here. It is almost beyond that the mid third level. You can even appreciate the furcation bone loss over here. So because it's vertically placed, we are able to get more surface area almost up till the apical third. So for severe bone loss, this vertical Bitewing projection modification could be helpful, and this can be used in the anterior teeth region as well. Here is another case where you can see the furcation bone loss. Next one, in case of a mandibular tori, what is it? In case that is what? That is basically a bony outgrowth. You can clearly see in the image over here on the lingual aspect, you can see a tori. So what do we do in such case? Do not place the film on the tori. Okay, it's better to place the film between the tori and the tongue. In some cases where the tori projection is much more, what will happen is the tab that the patient has to bite on won't be sufficient. The tab will also go way behind, and he won't be able to bite it. So in such cases, what you can do is combine two tabs, stick them together, so you get a longer length tab. So even if this film goes more behind, you'll have a long tab so that the patient will be able to bite. So that ends with the modification. Now I have a few example images here. Why don't you also try, as before I speak, try to guess what the errors may be in these Bitewing projections. Here you can clearly see it's neither a premolar Bitewing image nor is it a molar Bitewing. Why is that? See, even if it is a premolar, clearly the premolar is cut over here. So it is not the ideal premolar. Even if it is a molar, you can clearly see it is cut. So nor is it either of them. Even in this case, you can clearly see both are not appreciated. Let's say if this was a molar, unfortunately, you have to, like I said, you have to consider the third molar also if it is erupted. So the film should be placed in such a way that all the three molars are appreciated. How about this second error? Can you all guess what it is? You can clearly see the whole alignment has changed of the film. See over here, the alignment is on parallel, literally the occlusal line. Can you see this? It's parallel to the edge of the film. If you can see this, the whole alignment is gone. In the process, you're not able to appreciate the maxillary teeth here, nor over here. This would have happened why? As I mentioned earlier, probably the film was placed too close to the palatal bone, thereby patient would have pushed down the whole film. This is the end result of it. Over here, it's a clear case of a cone cut. This is not, the film placement is ideal, but what has happened here, the point of entry is wrong. You can see the PID or the central X-ray is not in alignment with the film. Let's say this was for a molar projection, right? The ideal central point should be near the outer canthus of the eye at the level of occlusal line. So the point of entry should have been here. Clearly, that is the center of this dotted circle. Whereas what has happened over here is it's gone beyond that. The central X-ray is here. So that is way beyond the outer canthus of the eye, thereby resulting in a cone cut. What would be the error of this? Let me give you 2 seconds. So what you can clearly see here is there is a large gap between the two occlusal surfaces of the maxillary surface and the mandible surface. The patient has basically not bit on the bite block or on the tab properly. So you can clearly see here the distance over here, and in this one is a large gap. Okay, so positioning and placement of film is also very important. Okay, now I shall give you a live demonstration of the RIN XCP. Moving on to the live demo, you can see this is a RIN XCP. This is the plastic bite block, the aiming ring, and this is the indicator arm, metal indicator arm. So I have placed the film here into the bite block. You can see over here. The film should be placed in such a way that the white part is towards the ring, because the X-ray beam will come from here, right? So that's the white part should be facing this way. So let's say this is the mandible and this is the maxilla, and this is how we place it onto the occlusal surface this way, and the patient is gently made to bite, and the PID is placed this way. I'll change the angle so you'll be able to appreciate it. So this is how it will be, and the PID will be placed over here. You can clearly see from the intraoral aspect, this is how it is, and we have to maintain a slight few distance so the palatal bone is not touching the palate. Let me show it to you from another angle. Don't place it very close over here, it should be placed slightly away. Okay. Now there is another small hack. In case you all don't have the RIN XCP or the Bitewing tab, one way you can do is you can manually make one as well. Let's say just take a sterilized, it should be sterilized paper like this, okay, fold it, and what you can do is position the paper like this. The white part will be facing the PID, right, intraorally, and this will be the tab where the patient will bite, like this. So this is a makeshift just in case of emergency. So that concludes our topic for today. So overall, let me summarize in the conclusion. How is the film placement? Film must be placed to cover the area of interest. How is the film positioned? The film must be positioned parallel to the crowns of both the upper and lower teeth and stabilized by biting on the film holder or the tab. What is the vertical angulation? The central X-ray must be directed at plus 10 degrees. Then we have what is the horizontal angulation? The central X-ray must be directed through the contact areas between the teeth and the film exposure. The X-ray beam must be centered on the film to ensure that all the areas of the film are exposed, and thus partial image or cone cut is avoided. So these are my references. Thank you.